Well, good morning, everyone. Welcome to Pediatric Grand Rounds. I come to you, of course, live from the Children's Hospital of Pittsburgh Broadcasting Studio, where I can tell you it's 72 degrees. There's not a cloud in the sky. It's a beautiful, beautiful day. This is the third in our series of COVID-19 updates. And as we approach what we hope to be the beginning of the end of the COVID-19 pandemic, our Grand Rounds this morning is focused on lessons learned. We have three outstanding speakers. I'm going to introduce them all now, and then we'll go ahead and proceed with the presentations, and we'll have some time for questions and answers at the end. First up is Dr. Kate Kernan. Dr. Kernan is Assistant Professor of Critical Care Medicine. She earned her MD degree from the University of Pennsylvania and completed pediatrics residency at Washington University in St. Louis, and her critical care medicine fellowship at UPMC Children's Hospital. She joined the faculty here in 2018. Dr. Kernan is an outstanding physician scientist and is the critical care medicine representative on the American College of Rheumatology Multisystem Inflammatory Syndrome in Children Task Force. Dr. Kernan is going to discuss what we have learned about severe manifestations of COVID-19 in children. Next up is Mr. Sam Reiman. Mr. Reiman is the director and a trustee of the Richard King Mellon Foundation, which is the largest private philanthropy in Pittsburgh. He received his BA degree in science, technology, and public policy from Franklin and Marshall College, an MS degree in public policy and management from Carnegie Mellon University, and an MS degree in biotechnology from Johns Hopkins University. Yes, indeed, Mr. Reiman likes school. In his capacity as RK Mellon Foundation director, Mr. Reiman oversees the foundation's administrative, programmatic, community, and strategic planning functions. Mr. Reiman will share his experience with the philanthropic response to COVID-19. And last, rounding out the program, is Dr. Debra Bogen. Dr. Bogen is director of the Allegheny County Health Department, a role she assumed in March of last year. Dr. Bogen has always been a master of perfect timing. She earned her MD degree from the University of Colorado School of Medicine and completed both her pediatrics residency and general academic pediatrics fellowship at Johns Hopkins Hospital. Prior to leading the Allegheny County Health Department, Dr. Bogen was professor of pediatrics at the University of Pittsburgh and vice chair of education in our department. Dr. Bogen has guided our county through numerous and unpredictable challenges of the COVID-19 pandemic, with her focus most recently on the equitable and universal distribution of COVID-19 vaccines. Dr. Bogen will discuss how the Allegheny County Health Department responded to COVID-19 and make some bold predictions about the future. Now, I've asked this outstanding group of speakers to spend about 10 to 15 minutes on their topics, which should leave us some time for discussion. Please post your questions up in the Q&A, not the chat function, but the Q&A, and I will try to get to as many as I can. Thank you and welcome, Dr. Kernan.
Right, so let me get this set up. All right, good morning, everyone, and thanks to Dr. Dermody for the introduction and to the Department of Pediatrics for this opportunity to speak. I'm Kate Kernan, an assistant professor of critical care medicine at the Children's Hospital of Pittsburgh, and I'm going to talk today about severe pediatric illness and SARS-CoV-2 infection. Thankfully, the majority of SARS-CoV-2 infections in children are either mild or asymptomatic. However, the risk for severe illness is non-zero and largely comes in two forms: viral respiratory illness in acute COVID-19 and in the multisystem inflammatory syndrome in children, or MIS-C. We'll begin today by discussing viral respiratory illness in acute COVID-19. This heat map is taken from Yonker et al. And depicts the presenting symptoms among children seen at MGH in mid-2020. Among those children seen with acute COVID-19, typical symptoms were of a flu-like syndrome, including rhinorrhea, headache, sore throat, cough, and fever, with only anosmia representing a specific symptom that was reported in around 20%. Epidemiologic data of severe pediatric COVID-19 suggests that around 5% of cases are admitted to hospital, and around 30% of those will receive ICU care. US data suggests that pediatric mortality is around 0.1% of PCR positive cases, a rate that's comparable to CDC estimates of RSV-related deaths. Groups more commonly associated with severe disease include those less than 1 year of age, those with medical complexities and select comorbidities, as well as variable reports of more severe disease among children of African, Hispanic, or Asian ancestry. The top right figure shows comorbidity data from the Satsi et al. Study of 26,000 PCR positive children from the United Kingdom, showing an increased odds of hospital admission for those with type 1 diabetes, congenital heart disease, cerebral palsy, epilepsy, and sickle cell disease, with a trend towards increased admission in those with asthma. Once admitted, groups at risk for severe disease are similar, as demonstrated by the Companiet's figure on the bottom in a study of 43,000 US COVID positive pediatric encounters, with an increased risk of intensive care or step-down unit admission, use of mechanical ventilation, or death in those with type 1 diabetes, congenital heart disease, epilepsy, obesity, and hypertension. Few studies have focused on describing the illness course of children requiring ICU admission for acute COVID-19. The two largest studies include case series from Paris and North America, showing that PICU admissions for SARS-CoV-2 infection are most commonly seen in children with neurologic comorbidities. Its typical course is of single organ lung failure, requiring mechanical ventilation in approximately 40%, with 15% ultimately requiring advanced therapy for respiratory failure, including prone positioning, inhaled nitric oxide, ECMO, or plasma exchange. Approximately 1/4 of these individuals will develop multisystem organ dysfunction, typically with either cardiac or renal involvement, resulting in a median hospital length of stay of around 6 to 7 days, with 4% mortality in those children. Current treatment for COVID-19 in children mirrors that of adults and centers around antiviral and immunomodulatory therapy. Antiviral treatment is supported by the ACT-1 trial, showing that remdesivir was superior to placebo in shortening time to recovery by a median of 5 days, with a trend towards decreased 29-day mortality. Immunomodulatory therapy with dexamethasone is supported by the recovery study, where it was associated with a decreased 28-day mortality, most notably in the sickest patients requiring either oxygen or mechanical ventilation. And finally, in select populations requiring ICU care or O2 supplementation with elevated inflammatory markers, tocilizumab has been shown to decrease mortality and increase organ failure-free days in the recovery and REMAP-CAP trials. Data surrounding the use of these therapies in pediatric ranges are relatively lacking, but we anticipate data on these questions from the UK Recovery Research Group. In Caravan, a Gilead-funded single-arm open-label study of remdesivir for safety, pharmacokinetics, and efficacy in children, and in the NICHD Pediatric Trials Network POP study of safety and pharmacokinetics from commonly prescribed drugs in pediatric populations. The second portion of my talk will focus on multisystem inflammatory syndrome in children, or MIS-C. Jumping back to that heat map of presenting symptoms from Yonker et al. And an added schematic from Belhager, we see that kids with MIS-C more commonly present with fever, rash, and abdominal complaints in comparison to those with PCR positive COVID. They were originally recognized as displaying many of the stigmata of Kawasaki's disease, a pediatric medium vessel vasculitis with mucocutaneous involvement, including conjunctivitis and rash, that in severe cases can develop signs of distributive and cardiogenic shock, as well as coronary artery dilation. In May 2020, the CDC issued a case definition for MIS-C, including children less than 21 years of age presenting with fever, lab evidence of inflammation, and multisystem involvement, in the absence of alternative explanation and with recent evidence of SARS-CoV-2 infection. The CDC reports that there have been 4,000 US cases of MIS-C and 36 deaths through June 2nd. Recent reports have estimated that the incidence of MIS-C is approximately 316 cases per 1 million SARS-CoV-2 infection in children less than 21 years of age, with a risk that varies by racial and ethnic group, being highest among African Americans. Versions of the figure to the left may be familiar, showing Allegheny County cases of probable and confirmed COVID-19 in orange with scale on left, and the MIS-C presentations to CHP over the same time period in blue, scale on right. The observed lag in MIS-C cases is approximately 4 to 8 weeks after peak incidence of SARS-CoV-2 PCR positivity and has been demonstrated reproducibly on both the individual and population level, with the next graph representing nationwide trends. These data are the epidemiologic evidence for MIS-C as a post-viral inflammatory complication of COVID-19. Efforts are ongoing to understand how MIS-C develops. On the left is a figure taken from Gruber et al., showing the results of principal component analysis of cytokine profiling from peripheral blood samples of children with MIS-C, acute COVID-19, and healthy controls. The MIS-C samples are shown in yellow and occupy a unique cytokine space that can be defined in part by the expression of IL-6, interferon gamma, CXCL11, and IL-7A, all key signals in T-cell response. Then on right, the figures taken from Bella et al. Show an increased proportion in the number of HLA-DR positive, CD38 positive, CD8 T cells taken from peripheral blood samples of MIS-C patients in comparison to those with COVID-19, demonstrating that MIS-C patients have a higher proportion of viral responsive T cells. Further lymphocyte subphenotyping showed that these CD8 T cells were commonly vascular endothelium homing, marked by their expression of the endothelial receptor CX3CR1, and that patients with MIS-C demonstrating a vasoactive infusion requirement had a statistically significant increase in the proportion of these endothelial targeted CD8 T cells, which also correlated with other markers of endothelial damage, including D-dimer and thrombocytopenia. Treatments for MIS-C have evolved from experience with Kawasaki's disease, centering on the use of IVIG and steroids, with a growing body of literature suggesting that combination therapy may be superior to IVIG alone. First, reports in a pre-post study from Belhadra et al. Showed that combination therapy was associated with a decreased time to echocardiographic recovery of LV systolic and diastolic dysfunction. Then Udali showed in a propensity score analysis that combination therapy was also associated with a statistically significant reduction in persistent or recrudescent fever, as well as decreased duration of LV dysfunction, need for second-line therapy, hemodynamic support, and shorter ICU stay. Finally, the figure to the right from Son et al., taken from the New England Journal of Medicine, shows an association between combination therapy and a statistically significant reduction in cardiovascular dysfunction and need for other immunomodulatory therapy when using propensity score and inverse probability weighted analysis. Upcoming, we anticipate the results of 2 RCTs aimed at answering these questions more definitively. In the MYSTIC trial, comparing IVIG plus anakinra or infliximab or methylprednisolone, and the head-to-head methylpred versus IVIG Swiss PED recovery study for the treatment of MIS-C. Of note, while the incidence of MIS-C has drastically decreased across the United States in line with following PCR positivity tests, it's important to note recent reports of a possible link between SARS-CoV-2 vaccination and MIS-C and myocarditis. This month, the CDC released a report in emerging infectious diseases of 3 cases of multisystem inflammatory syndrome following vaccination in a 18, 20, and 40-year-old. And an additional 7 cases of myocarditis were reported in June's issue of Pediatrics, though it's important to note that these teenagers showed no other clinical signs of inflammation consistent with MIS-C. Lastly, I'd like to briefly point out the other unanticipated effects of the pandemic on the health of children. In the top panel is a graph showing the increased proportion of child abuse and neglect-related ER visits over the pandemic year. In the middle panel displays a 63% decrease in rates of MMR administration among children between ages 2 and 8. And the last panel demonstrates a change in proportion in mental health-related ED visits in 2020. Alongside an increase in proportion of those visits requiring admission at a tertiary care children's hospital. All told, these data suggest that we're only beginning to understand the impact of COVID-19 on children's health. So in sum, I've shown you that SARS-CoV-2 has had a measurable impact on children's health, which while less frequent than seen in adults, is at times equally severe. and that the manifestations include acute COVID-19 related respiratory illness, the newly described multisystem inflammatory syndrome in children, and other unanticipated health effects we're just beginning to appreciate. With that, I'm going to hand over to our next speaker.
Great, thanks, Kate. That was just terrific. Next up, we have Mr. Sam Reiman, who is going to discuss the philanthropic response to COVID-19. Sam, welcome to Pediatric Grand Rounds.
Thank you so much, Dr. Dermody, and it's a pleasure to be here with everyone. One message to Colleen, I'm trying to start my video and it's saying that it has been stopped. So I'm not sure if that's something you can, there we go. Perfect. Great to meet everybody virtually. And I'm going to share my screen here to talk about the role of the philanthropic sector in Pittsburgh during the past year of COVID-19. Okay. Great. So again, pleasure to be with everyone today. And the first part of this is just kind of the overview of what I wanted to discuss with the group, which is the way in which the foundation community, along with so many others in the community, were forced to respond to a historic pandemic. And what were the lessons that we've learned as a result, now that we can reflect back on the past year, understanding that so much of the work that we're doing continues in a variety of different ways. The first lesson that we learned was that when COVID first hit, we moved fast. And when you think about the foundation community, this is a group that it responds to crises throughout the years in ways that it's very difficult for other entities to respond with that same level of speed and agility, in part because we have small boards of directors. We're able to go back to them and pivot to a different strategy, and we're able to do that using data and in real time. And that's exactly what we did. I think when we saw what was happening beginning in late February, early March, the very first thing that we did was to think about what are the different ways that we can respond to this crisis. The first was, as a foundation community, for us to come together with some of our peers, including at the Heinz Endowments, the Pittsburgh Foundation, and the Hillman Foundation, to put together a shared fund that we established over at the Pittsburgh Foundation that could be used to address the immediate needs in the health and human services space, predominantly with a focus on supporting the work that Dr. Debra Bogen, when she will talk later today after my session, will mention a few of those projects, but also with the County Department of Human Services for them to be able to get the critical emergency support to people who were most in need in the community. After we made that initial grant, we took a step back as a team and said, what are the areas that we can focus on with intention over the next 12 months? And those three categories included our work in health innovation, which for us also allowed us to make direct investments in for-profit entities that were doing work around therapeutics or vaccine development. It included technology, such as the use of rapid diagnostics for COVID-19. It included the use of apps. It included the support of the production and manufacturing of personal protective equipment. I'll talk a bit more about that as an example later. And all of that was bundled together in one category. The first category that we funded was around emergency operating support. And we got inundated with a wave of requests from virtually all of our partners. And unlike the financial crisis, where it was fast and rapid, but didn't affect the entire sector, this was more like a tidal wave. And what we found was that there was a need for emergency support across the board. And our first wave of grant making reflected that, particularly as it related to arts and culture and some of the immediate needs that we were seeing coming out of communities that were shutting down. And then the last part of it was getting our hands wrapped around sort of the economic impact of the closures for businesses, schools, and every institution in the entire county and across the country, and to think about what are those strategies that we could prevent further job losses, but also to be investing in what we would anticipate to be the economic recovery that follow the reduction of cases of COVID-19. And so we moved quickly. What you're seeing here are some quotes from an article that appeared after the board met in an emergency session to make its first award as part of this strategy of $15 million. For us, again, it was built around those three key pillars. And the other part of this as a foundation, and something that we, as someone in this space who's been working in the sector since 2007, I had heard all of these wonderful stories about how the foundations responded to the collapse of the steel industry and past crises. So this is not something that's new. I was at the McCune Foundation during the financial crisis, so I lived through that. But one of the things being in this role that occurred to me is it's important for leadership to step up and demonstrate that people are paying attention to this, and there's some effort to at least provide a sense of stabilization that that there are resources being directed at this, and that there are a lot of people that are trying very hard to figure out how to solve some of these problems. And just from a communications perspective, something the foundation had never done in its 73-year history, this provided an opportunity for us to share transparently with the community what we were trying to do, and also to recognize the fact that we were one of many philanthropic partners in the community, and that we have an abundance of strategic partners such as the Children's Hospital to be able to carry out the work that we do. I'll go into some of the examples then of the work that we did last year. We just published our 2020 annual report, which also for us is a new spin on the way that we've reported our work in the past. It's a composite of 15 stories of how the work that we did over the course of the last year impacted individuals. And so I would encourage you to read that, to download it for our website. I'll go and brief over some of the high level elements of that. But if you want to understand how people were genuinely impacted in really emotional, meaningful ways over the course of this last year, we worked very closely with the journalist and others to be able to capture some of those stories. While the initial grants that were awarded by our trustees were $15 million, by the end of the year, we had awarded over $33 million to COVID relief. That represented about 30% of our total giving for the year. And there were a wide range of efforts that we supported. Some of them were expected, some were creative, but all of them were consistent with our initial plan that we stood up with the Board of Trustees here. A few different categories. One, of course, is food. No surprise that the shutdowns and the loss of income as a result of the economy coming to a halt resulted in a lot of people needing food in a way that they had not before. One of the stories in the annual report is about a family that had never gone to the food bank in the past. We were hearing these stories consistently, people not knowing that that was a resource, also feeling a great sense of it was difficult for them to go and sit in a line like what you see here, this very famous picture that was displayed all over the country of the line to the Greater Pittsburgh Community Food Bank that extended several miles not long after the pandemic began. We provided $1.2 million to the food bank over the course of the year. They were fortunate, of course, that they ended up receiving generous support from a multitude of donors, not just philanthropy, but also many individuals and corporations. To be able to respond to the overwhelming need. They gave out 46.3 million meals, about 20% increase over the previous year. We also funded the food bank in Westmoreland County, where similarly, they had a population there that had largely not been using the food bank. So in addition to funding for food, we had to fund marketing costs so that they could spread the word about the availability of that resource and how people could access it. The other funding that we provided in the food space more directly was to the Pittsburgh Downtown Partnership, seeing the impact of the closures on downtown in particular, where the majority of the restaurants were fully dependent upon employees coming into the office on a daily basis. Many of them were closing. Our concern as a foundation, having invested close to $100 million in the revitalization of downtown Pittsburgh over the last 30 years, was that after this ended, that we might likely find ourselves with very few amenities left in the form of restaurants, and in particular the arts, which is a separate category that we invested in rather significantly to make sure that when things do reopen, that the arts will be available. But we provided $1.5 million to the Downtown Partnership, which they then used to work with 15 different restaurants or 24 locally owned restaurants, and also some other partners to prepare meals that could then be served to individuals who were food insecure. And that provided them with enough cash to work through some of the more difficult months of this past winter when cases were spiking. One of the initial grants that we awarded out of the gate that Dr. Bogen can reference as well is the work that we did with the Allegheny County Department of Health to help acquire 1,700 plus COVID tests. I know that that number has risen dramatically because this is an effort that continues. The foundation's role in this was unique in that we were introduced through our networks to a group out of Los Angeles called Curative that had developed a rapid oral diagnostic. You'll recall this was in a moment when it wasn't clear which diagnostics were working. Some of them had emergency approval through the FDA, others had not. There were efforts to have home-based tests, and those were being pulled off the shelves. So it was interesting to kind of look back and reflect on this and talking with Dr. Bogen and all the other experts around not just the need for these tests in the poorest communities in Pittsburgh, where individuals didn't have access to transit and couldn't drive to, say, the Pittsburgh Zoo in order to wait in a line, but also just, are these tests going to work? And how do we get the results back quickly enough such that it actually is useful? So the lab for Curative was in Los Angeles. We worked also with Argo AI, and that's a relationship that the county had as well to use their network of self-driving cars to pick up the completed test, take them to FedEx, get them to Los Angeles, and get the results back to the federally qualified healthcare centers in time for those results to be meaningful. And so from our perspective, that was a great example of how philanthropy, the public sector, and the private sector can work together in real time to address a pressing need. Personal protective equipment, it will come as no surprise to everyone on this call, the deficit in terms of availability of these supplies and just how scarce those resources were during the peak of the crisis. The foundation had made grants in the past to support innovation in manufacturing, and one of our partners, Dayal, which runs a large manufacturing center out of the Homewood community in Pittsburgh, was able to quickly pivot its lines to be able to produce plastic face shields and masks. And its first order came from the Allegheny Health Network, where it was able to produce over 200,000 plastic face shields and completely revamped its workforce, separate from its ability to then produce equipment that was used in the hospital settings and other clinical settings. It saved the company from going bankrupt, as their primary resources came from their sale of branded products that they make through Dayal. And it's worth noting that they now, in the past few months, have had their most successful months in terms of sales of retail products. So again, an example of how we were trying to figure out how to be creative to support organizations that we had supported in the past, taking advantage of the assets that they had in this case to be able to produce those types of personal protective equipment materials. Education, of course, no surprise here as far as the issues that we anticipated from the very beginning, with schools shutting down and also with the closure of the economy. Our concern right out of the gate was that you'd see a few things happening. The first being that students who were in high school and looking to go to college may end up delaying that by more than a year, in which case they may not go back. And then students who were already in college and didn't have resources to complete their education would drop out. So there were a couple of grants here that we awarded. One was $1.35 million to the Pittsburgh Promise. That was an emergency grant, again, described in detail in our annual report with Salim Gubriel, where we had a quick phone conversation in early April. The idea of an emergency fund emerged, and because of the nimbleness with which our board allocated resources to address these issues, just a few days later, we had that money out in the field. That allowed the Promise to then work directly through its network of thousands of scholars to understand what their financial gaps were for tuition, but also what their immediate needs were in terms of food, housing, and other insecurities that they could help to address with that support. In addition to that, we provided $2.5 million to 15 colleges and universities to help with their reopening plans. That truly was operating support. If a college needed it to purchase tests, or they needed it to just support students so that they'd have a better ability to come back and live on campus and pay their tuition that year, we left it open to those institutions to decide what was the best way to support their students and to reopen in a safe way. Of course, our efforts also couldn't have taken place without our partners at CHP. A few of the grants that we awarded and are quite proud of course, are the work that we did to help support the clinical trials, which included the Moderna trials, and also the distribution of vaccines shortly thereafter. Once again, this is a story that we tell in detail. Dr. Dermody's support and always catchy quotes. Thank you, Dr. Dermody, for telling such a great story about such a trying time. And then we also, it's worth noting, while COVID was in progress, we're still looking at the other needs of the hospital and the other types of issues that we anticipated. We awarded another significant grant to Children's Hospital to develop a vaccine for acute flaccid myelitis, AFM, and while sort of the kind of unintended consequence of us all distancing and wearing masks was that respiratory illnesses have declined significantly, we thought it was still important here, thinking out into the future around the uptick in AFM cases, particularly what's been seen here in the region, for CHP to be a leader in developing new therapeutics and vaccines for that virus. And while we were doing all of that, we finished a new 10-year strategic plan. So this had started in earnest 2 years ago when I became the new director of the foundation. And we announced that plan in early January after my board approved it in late December. And that's an ambitious plan to award over $1.2 billion over the next 10 years. It focuses on 4 core areas, 2 of which were heavily influenced by what we learned over the last year, but had already been in motion. So the last year in particular simply reinforced for us the necessity around dealing with poverty and creating strategies to enhance economic mobility for the individuals who are poor, both in Pittsburgh, Allegheny County, and Westmoreland County, so that they can achieve greater wealth and prosperity over the course of their lifetime. And then the second being health and well-being, which for us was previously our human services program that we have since merged kind of our healthcare related grants and our social service human services. So that intersection of health and the social determinants of health is something that we're heavily focused on for the next decade. We also, based on the work that we did in part to support for-profits that were doing work to address COVID-19, we created a separate program called Social Impact Investing, which allows us to invest directly in for-profit companies that have some social mission component to what they're doing, which is often very clear in the life sciences space. And then also organizational effectiveness is a new program, which is intended to allow organizations to be adaptive and to respond to the changing needs of the community, but also to be prepared for these types of events, such as the COVID-19 pandemic, if and when they do occur again. The lessons learned, and there are many, and so this is in no way comprehensive, and part of this is in the mortality and morbidity sessions that we go through here at the foundation. There's a lot left for us to learn and understand from what's taken place over the last year. But a few of the highlights include Pittsburgh is unique. We have a concentration of large, locally focused foundations in a way that most other major cities do not. There have been a ton of stories written about the impact of this, in particular in providing a stabilizing force during the collapse of the steel industry. We see a lot of great philanthropies all over the country. Many of them, though, do not have a singular focus on a geography such as their own backyard. And so that concentration of resources and knowledge about the community certainly was an advantage for us to be able to move quickly. Access, again, to that historical data as a result of having gone through multiple versions of this crisis allowed us to respond quickly. There's the national data that we were looking at, but we didn't have to wait to understand what was going to take place in the communities because we had seen this unfold so many times before. So rather than us kind of being behind the next wave of crises as a result of everything that was taking place, we worked very diligently to get out in front of that. I think one of the things that we still learned, though, was that we as a foundation need better access to real-time data. It's one thing to project broadly about the needs for food insecurity in the Homewood community as an example. It's another if we would be able to know that on this particular block, there are 10 people that are Google searching, how do I get access to food, right? So it was a reminder that the corporate sector has an abundance of data that we still weren't able to bridge that gap to be able to be even better in making decisions to target our resources to people that needed them the most. That being said, as a foundation, as I mentioned in the beginning, we had the ability to move quickly in terms of our governance model. For me to go to the board and with the rest of my staff to make the case that we needed to do this work, this is the strategy, and to ask for an allocation that would allow us to move quickly without having to wait for another board meeting in order to award those funding, those grants. I had the ability to go back to my executive committee and we just drew down on those funds over the course of the year and then continue to re-up them based on the need in the community that we were seeing. And that's something that truly did allow us, the ability of my board to pivot in that way, and as quickly as they did, certainly made a huge difference. Leaning into science and technology, again, we were following the data, but we looked directly to our partners, the experts in the field, the individuals leading entities like the Department of Health, Children's Hospital, and other places around the country, Paul Dupree at the Center for Vaccine Research, and investing in all of those leaders because we knew that many of the solutions that would emerge to this crisis were going to come through those partnerships and through those institutions. We saw the imperative need for local manufacturing. It only reinforced what we had observed going back many years because of the foundation's work to support the manufacturing sector here in the region. And this, again, if for those individuals that hadn't recognized prior sort of the issues with not having access to local manufacturing, this just highlighted it in the most dramatic way possible, as mentioned, around personal protective equipment. And we will continue to look at those needs and understand are there ways that we can create permanent infrastructure to fill those gaps. And then the organizations that we serve, right? So none of this work that I'm describing is possible without the organizations that we fund. As a foundation, we don't deliver any services. So our role is to provide capital, to provide access to our networks, to provide a spotlight on some of this work through our communications. And those are really the three core assets that we have when we bring to these issues. But really it was the organizations we work with that had to be creative and adaptive on the spot. Certainly you heard a few of those stories. There are many, many more of them in the arts and culture space, but we were not surprised, but certainly pleased to see the way in which organizations here not only came up with creative ideas to survive the pandemic, but to partner with each other and to come up with completely new ideas on how to deliver their services that certainly will persist well beyond the pandemic. And with that, thank you. And we'll turn it back over to Dr. Dermody.
Sam, that was terrific. And I join legions of Pittsburghers in thanking you and the foundation for all of your support during the COVID-19 pandemic. Truly heroic, and thank you. We next turn to Dr. Deb Bogen, who's going to talk about the Allegheny County Health Department response to COVID-19 and make bold predictions about the future. Dr. Bogen, thanks for joining us. Deb, you may be on mute.
Sorry about that. Thanks, Terry, and thank you really for inviting me today. It's really an honor and a pleasure to be joining you all on this panel and really to be back with my friends and colleagues, albeit virtually, at Children's. So Dr. Dermody gave me a rather tall task. He does that sometimes, you all know. He asked that in less than 14 minutes, I address some major questions. So these are the 4 questions he asked me to address. So I hope I can do that in the next 14 or so minutes. So the first question was really about mitigation strategies and what worked. So I'm just going to remind us that the goal of our mitigation strategies were really to reduce cases and the spread of those cases to other people. And that was really important to ensure that our healthcare system had the capacity to handle the cases, and to ensure that our public health system had the capacity to handle those cases, including our ability to provide testing, case investigation, and contact tracing. So mitigation or strategies come in wide variety. The most far sweeping are public health orders, but they include isolation and quarantine, mask wearing, physical distancing, limiting gatherings, and vary from location to location. So nursing homes versus hospitals versus other places. So let me walk you through our thinking. I've sort of dubbed the pandemic in Allegheny County as having 6 phases. And I've given these names just for my own clarity in my mind as I think past across the last year. So from March to May of 2020, I refer to that as the phase of unknown and uncertain. We had really limited information about the virus and how it acted. We had very limited personal protective equipment and testing capacity, and really no proven treatments. And so really, due to the uncertainty and what we were seeing in other parts of the world and in the country, and our relative unpreparedness for this pandemic, the public health mitigation response was broad and large scale and much more like a sledgehammer than a scalpel. And we gave big orders, right? We had non-essential business closures, stay-at-home orders, school closures, and eventually we started talking about the phased reopening. But those were big and sweeping public health orders, and they were necessary at the time because of all that uncertainty. But as we learned more information about the virus and our capacity to respond, we went into the green phase, and that was in June. And at that time, we had somewhat of an increase in testing availability. Therapies were beginning to emerge. We knew much more about how the virus spread. But unfortunately, people heard green, which means to go for many people. And indeed, they went. They went on vacations, out to dinner, to bars. And we unfortunately experienced a surge in cases, hospitalizations, and deaths. And so based on what we were learning from our case investigations at the health department, we could really pinpoint the source of where people were spreading infection. And we tried to make our public health orders more strategic rather than the sledgehammer. We were trying to get to a small hammer at this point. And we did things like reducing alcohol use, closing bars and restaurants, limiting event sizes. And Pennsylvania at that point also implemented the mask mandate, and really talked increasingly about physical distancing as well. So from September and October into what I call the preparatory phase, cases were relatively low. Our mitigation strategies worked quite effectively. Testing was increasingly more available. Therapies had improved. We had much more ample personal protective equipment. And with that, we had relaxed public health orders. And during that time at the health department, we recognized we were very concerned about a winter surge coming, and we did a lot of hiring, a lot of training. And one thing we did, which I think was very forward-thinking and was adopted by the Pennsylvania Department of Health, is we prepared an online case investigation form that we trialed through the curative program because everybody was registering for that electronically. So people had emails, we could send them the online case investigation form, and we trialed and compared that to our phone system. And then of course in November and December, we had what we had assumed we would have, which was the winter surge. And although cases at that time far exceeded those at any other time in the pandemic, we didn't put in place the same kind of public health orders. We put out a public health advisory. We continued to talk and limit sizes of gatherings, but we didn't have those same sledgehammer approaches because we were learning about how to respond. And also the vaccines were on the horizon. And in January through April, which I call the vaccine rollout phase, the public health orders were gradually relaxed, but we encouraged, again, mask wearing and physical distancing still, and getting more and more refined and really putting in place in specific locations different strategies rather than across the entire community. And of course, now we're in what I call the overcoming vaccine hesitancy phase, and we are have all ended all public health orders, but we still have targeted strategies in high-risk places like nursing homes, in child care centers, and things like that. All right, so I'm having trouble moving. There we go. So what did we learn? So key strategies we used was really to be responsive to the data and the trends. And we deployed mitigation strategies in response to a host of factors, not just one piece of data. We, and I personally learned very quickly about the importance of frequent, honest, and transparent communication, including saying, I don't know a whole lot during this pandemic. And I think that's really important to be able to say. And I would say the thing we learned most importantly is that collaboration really is essential. So early on in my time here, the chief of staff from the county executive's office, Jen Liptak, said to me, Dr. Bogen, you need to remember Allegheny County Health Department is not an island. Ask for and accept help from everybody. And that was really sage advice. And I really heeded that advice. And we really did take help from every part of the community, from foundations You heard from Sam Reiman about their generous, amazing early care. You know, early on, the CARES Act funds took a long time to come down the pike, and it was the foundations that provided funding for our the Safe Haven Hotel, for the curative testing. So really that was essential. We had support from community organizations, healthcare organizations, the business community, universities, and all branches of government. I don't have time to talk about all of the work that was done, but it was truly amazing. And I want to share with you an example of where collaboration was really effective. So I think it's really nice to talk in these generalities, but this is a real example. So when we got vaccine and we saw that it was coming in increasing supply, we were very concerned that we wanted to get those vaccines out to the most at risk for COVID-19, which is of course our seniors. And where are seniors? Well, they're all over, but we worried a lot about people's ability to get places that didn't have cars, transportation. And so we partnered, our Department of Human Services, our county staff, our county manager, and our housing authority helped us map all 174 senior buildings in Allegheny County. And then we prioritized those based on sort of economic need and location and cases. And we went to our vaccine providers across the county, including pharmacies, hospitals, doctors' offices, our federally qualified health centers. And we basically created a map and said, you can go on this map and sign up for a building and go out and do the vaccines in the building. And with the help of all of those providers and tons of volunteers, including we had EMS, we had Medical Reserve Corps members, we went out over about a month and a half and to all 174 buildings were outreach to, and about 160 accepted a vaccine site on the premises of their building. And if there were people who couldn't get out of their apartments to come down for vaccines, these providers all went up and provided vaccine in their apartments. So, and I think that is largely why we've had such success. And if you look at Allegheny County, nearly 100% of people 65 and older have been vaccinated in Allegheny County. And really, this is a demonstration of working together effectively, government, business, private sector, volunteers. What are our challenges? We faced a whole host of challenges, and I can just name a few. But one challenge certainly is balancing mitigation strategies, so that the good of the individual versus the good of the many. And that has been a really, we could have a whole grand round just talking about the ethics and the laws around that challenge. But it certainly was the result of many of my sleepless nights, was this balance. The other challenge I think that was overwhelming was the pace and the duration. This was constant marathon. It was really tough. The public's appetite for information and data have been insatiable. So we had to expand not only our team of case investigators and contact tracers, but also our data analytics team. It's been really an ultra marathon that didn't let up. Our teams worked 7 days a week for months, calling, doing case investigation, contact tracing, data analysis, and the needs kept changing. So there was constant readjustment. And so change is good, but change can be hard as well, but it was constant and unrelenting. I think the division in the country and the need to combat misinformation really added another layer of complexity. Again, probably a whole lecture's worth of discussion. And communication is and has been and will always be a challenge. You know, we don't have one TV station, one newspaper, and one website. We have hundreds and hundreds. And getting information, and everybody uses a different combination of information sources. And so getting consistent information to everybody has been a huge challenge. And I don't need to tell this audience that the inequities that are longstanding in our community were not made better by the pandemic. They were certainly made worse. And we know that not everybody had the ability to work virtually. They had to go to work in places where they were put at risk. And that resulted in a disparity in outcomes. So the equity issues remain enormous and a challenge throughout the pandemic and will remain a challenge going forward. We also had issues of supply chain, which were also significant. But again, let me share one success story, and Sam mentioned this already. So about 2 weeks into my tenure here at the health department, I started to have conversations with the federally qualified health centers and the need for testing in the communities, particularly communities of color and our low-income communities. But the current testing we had, which was, nasopharyngeal swabs that had temperature, you had to keep it cold, you had to get in the refrigerator, you had to get it analyzed quickly, made it very challenging in the federally qualified health centers. And so fortunately for me, Sam Reiman reached out to me and told me that he had this potential collaboration with Curative. And what was really remarkable, we learned, is that these tests were shelf stable before and after specimen collection. So they didn't need any refrigeration, and they could be shipped quickly. And so with the help and support of RK Mellon, before we had CARES Act funding, they provided the funding for this and to the FQHCs. And then Argo AI provided these self-driving cars. They did the logistics. They picked up these samples every day, delivered them to our county lab. We processed them and sampled and sent them via FedEx to California and then eventually to DC. But that really allowed us to respond quickly. And by mid-May, we had this program in place in all the federally qualified health centers around our community. And if you look at the disparity data in Allegheny County, you'll see that we did not have a disparity in testing after that date, meaning our communities of color actually had lots of testing. Unfortunately, that didn't translate into the outcomes for hospitalizations and deaths, but it did address that of testing capacity. So I'm just going to, Sam talked about supply chain. We all know supply chain is a huge issue. We didn't have enough PPE, testing materials, and other things. So that was a challenge. My current concerns are probably similar to all of you. What's happening with the variants? Will the vaccines remain effective? Do we need boosters? I continue to be concerned about vaccine and the equitable distribution of that and building confidence in communities that this is a safe vaccines. We need to continue to identify and implement additional strategies to overcome the inequities. I have some concerns about our future testing needs. What do we do about flu and RSV? We had almost no other respiratory viruses this past year, but that will probably not be the case in the coming year. There's still some issues in quality of tests and parents' reluctance to get testing, not just parents, people to get tested because of the resulting isolation and quarantine recommendations. We have ongoing supply chain. And one of my biggest concerns is ensuring that children get back to school this fall in person and also into childcare in person. My lessons learned are, like Sam said, so many. I sort of trying to pick my top 10. So important, the pandemic clearly showed the importance of science and technology and of team science. Science brought us tests, treatments, vaccines, telehealth, all amazing demonstrations of the power of science and technology. And I hope that means our country will invest even more in science and technology and promote that in our schools. We learned that inequities are made much worse in crisis, not better, and we need to be planning and mindful in addressing those now and not waiting until the next pandemic. Supply chain, we need a lot more planning in that area. And I think the other thing we learned is really that the social fabric of society and our connectedness to one another is really important for our wellness and our health. And how to do that and keep that connections during these trying times is really important. The other thing, obviously, is communication is key. We really need up-to-date plans before the crisis and how we're going to reach people and not trying to figure it out on the fly. We need better strategies to combat misinformation. And what I learned most importantly is really the collaboration, really working together brings the best results. And that was really demonstrated through all of the work across all of our sectors of our community who work together to address the pandemic. So these are our overall data. So just to remind people, this was a long time. We've had over 100,000 cases of COVID in Allegheny County. we've had more than 7,000 people be hospitalized, and we've lost nearly 2,000 people in our community. And although now our rates are low, we've had an up and down course, but it's made better by everyone working together. And these are just some photographs of all the sort of vaccine efforts that have been going on, not just by us, but by the community at large. So I thank you for your time, and I'm happy to be part of the panel and answer any questions.
Gosh, Deb, thank you so much for that presentation. Thanks more to you and your team for all your terrific work in the last 18 months. My gosh, we're so grateful that you're directing the Allegheny County Health Department. You all, we have about 5 minutes for questions, and as I anticipated, there are several that have been posted in the Q&A. Sam's already answered one of them. Those who are interested can click on the answered question and read Sam's answer. Let me start first with a question for Kate Kernan. Kate, Anita McElroy asked, how are post-vaccination myocarditis cases without inflammation being managed? Any therapeutics or supportive care only?
So, you know, from the case series that I was talking about, it looks like almost all, meaning 9 out of 10 of the patients received anti-inflammatory with corticosteroid treatment. The vast majority of them, I think, also received IVIG. I think it was 6 or 7 out of the 10 total cases. Some of the less severe of the presentations really were only managed with like either, you know, ketorolac or Motrin for pain control purposes only. One patient looked like was just treated with colchicine. So it seems like people have been pretty attuned to this and very aggressive with the treatment, even if, you know, the variable severity of presentation. In those 10 case series, only one individual had a vasopressor requirement. You know, so I think people are also being very mindful of the fact that we don't know a lot about this phenomenology, and you know, perhaps people are being you know, more conservative in terms of management strategies.
Terrific. Thanks, Kate. Sam, a question for you, or maybe you've already answered it because it just disappeared from my screen.
I did answer it.
Thank you. And I would say there's another question, Kate, that you might go ahead and answer in the chat. That would be helpful.
Sure thing.
Deb, there's a question for you, and it's from Kara Coffey. Kara asks, are there any changes from a mitigation standpoint that you're entertaining regarding the Delta variant? Anything that you would recommend we do differently?
That's a really tough one. We've tried to be responsive to cases and what's happening in our local community, you know, because we have the state and the CDC giving out information as well. So we're always sort of balancing what the CDC puts out, what the state puts out, and what we put out, and trying to be as in lockstep with those organizations as possible, because I think the more we differ, the more confused people get, and that communication strategy becomes challenging. So right now, our cases in Allegheny County are very, very low. We've only had 2 confirmed cases of the Delta variant, and interestingly, they were back from cases in April and May, not recently. So despite that being present in our community for at least a couple of months now, we have a declining number of cases. Our positivity rate is 1% right now, and our hospitalizations are really at an all-time low. So right now, I think if you're going to go out and be about in the community, this is the time to do it, because we don't know what the future holds. So I tell people, you know, enjoy your summer. It looks good right now. Get all that partying out, and we will be responsive to the data. If we start seeing a rise in cases, positivity, we'll sort of change our messaging. I was asked yesterday at our briefing what my personal habits are. You know, when I'm going into communities like a grocery store where there's lots of people, I don't know who's been there and anything. I am still wearing a mask, even though it's not mandated anymore, and I am fully vaccinated. So I'm trying to message to people that masks still work, and that there's no harm to use them. And use them to protect yourselves and others. But at this point, there's nothing on the horizon in our local community. But again, we follow the data all the time.
Terrific, Deb. Thank you. I just want to mention that both Loretta Mateo and Tanya Syed have nice notes in the Q&A, just complimenting you all on your fine work. Let me ask you, Sam, to comment a little bit on the effect of the bully pulpit. You were out front early in the pandemic with some of the programs that you had planned to support through the King Mellon Foundation. What was the influence of that public support on other members of the philanthropic community? You touched on it briefly, but I'd like to hear you expand on that.
Well, I think that certainly within this community, we work so closely together. So we continue to have a series of ongoing discussions with our colleagues, even after we supported that initial emergency fund out of the Pittsburgh Foundation. Part of what you see with foundations is that we all have missions that are similar in some ways, but also very different. But there was a convergence around COVID-19 that allowed us to make sure, especially with arts and culture and some of the health related work, all the things that I mentioned, that we were doing things together. But there were other examples that you saw me reference where we just decided that we wanted to take a very proactive approach to making sure that some of these needs were going to be addressed. You know, as I mentioned, sort of as we were looking at data, historical data, we had a good sense of what happens in the community when you hit 10% or even 15% unemployment. We then had to extrapolate that to 30 or 40% unemployment and understand sort of what the ripple effect was across these communities that we work in. So we were all coming at it from slightly different angles in some cases, but the collective ended up addressing so many of the needs that we found in those communities. I'd say, you know, going back to Dr. Bogen's point about what we learned about the inequities in these communities too, and how they became more severe as a result of this. There were also some really positive things that we saw emerge from this. I think also in part kind of based on funding we provided, and I think our foundation peers are in the same place, particularly around mental health in the Black and minority communities. The partners that we found that are doing extraordinary work to address those issues that largely had not been discussed prior to this pandemic. I think similarly, the other work that we were doing with other targeted populations that were in need of that type of support, that now it's just sort of fully understood that this is something that we needed to, as a community, take on, whereas in the past, it was always just below the surface. So I'd say the only other thing that the bully pulpit did was it meant that I had to explain more than I had ever imagined what polymerase chain reaction is in referring to the curative test. So at some point when I found myself being a spokesperson for the FDA, I thought maybe this is going too far. I need to just punt on some of this. It's not a normal thing for a philanthropy to be in that role, but we really did embrace our communications role, even though we were just finding our voice for the first time, as I mentioned, after 73 years. And, you know, I think it generated a lot of positive attention on the work that all of you have done.
Great. Thanks, Sam. And I say from our discussions, you could teach virology to the medical students anytime. I want to just, I know we're a little over, but there's one more important question, and it goes to you, Kate. It'll be the last one. Loretta Mateo asks, if you focus on the data regarding the risk for Black and Latinx children regarding morbidity, do you think that severity relates to social determinants and the comorbidities that come with those issues, such as obesity and challenging asthma?
You know, it's an excellent question. I think that the only kind of study that I saw in prepping for this that even attempts to address this is the SATSI study in JAMA from the United Kingdom. Really does focus on racial demographics in addition to kind of medical comorbidities. I think though, you know, while they're just so intertwined that I question how helpful, you know, it truly is to separate one from another. But I think, you know, in addition to the diseases that vary by ethnic background, also sort of questions about trust and timing of presentation really play a huge impact in outcomes from our perspective in the ICU. You know, to counter argument, my research is actually on understanding kind of genetic reasons for differing outcomes. And I will say they are really hard coded, immunologic variants that differ by racial and ethnic demographic that can, be posited to have a huge impact on outcomes. So I think it's all things. It's social, and it's biologic all at once.
Kate, thank you. You all, first, let me invite you, for those who have a few minutes, to join us for a meet and greet with the speakers. It's a different Zoom link. It's in the chat. You can find it there. And please join me in thanking Kate Kernan, Sam Reiman, and Deb Bogen for a terrific presentation this morning. You all have a great rest of the day. Take good care. Bye now.